you for your patience. I'm going to discuss, I was asked to discuss, and I'd like to thank the organisers for inviting me to the meeting, how to manage chronic pain. It's a very common symptom in people with polycystic kidney disease, and it may affect somebody transiently, or maybe become a chronic issue for some patients. And generally, the pain is often related to an enlarged, and what our PKD Foundation colleagues talk about, heavy kidneys and a heavy liver. And there are many medical therapies that can be offered to patients, and they have to be customized for what the problem is. For example, bleeding cysts, hemorrhage into the back of the abdomen after a cyst ruptures, and kidney stones. Those are examples of where specific medical therapies are needed. Surgical therapies are often desirable for problematic single kidney cysts, problematic large liver cysts. And of course, when the kidneys become very heavy and patients go into kidney failure, probably the best way to manage their pain is ultimately perhaps to take out the kidneys or get to a preemptive kidney transplant a little earlier, and ultimately either before or after the transplant to remove the kidneys. So bilateral nephrectomy is a treatment option, and bilateral nephrectomy and kidney transplant simultaneously has now become treatment option at our centre, which we've become quite proficient at. And again, stone management can centre around metabolic management, metabolically active stone disease, and surgical management of stones. And so pain is the most common symptom, perhaps 60% of people. And I show this slide of a patient of mine with very mild polycystic kidney disease, a teenager, and you would think, gosh, they don't have a lot of cysts in their kidneys aren't extremely enlarged, but this person actually is debilitated by their pain. And it's an example of someone that needed to go to extreme measures in order to control their pain. But this is somebody with chronic pain. Most of you that have polycystic kidney disease, in fact, have more problems with acute pain, perhaps with a urine infection, a kidney stone, a ruptured cyst. It can cause pain for several days. It can be moderate, it can be moderately severe. It can even require an emergency room visitor or hospitalization. Bleeding from a cyst, bleeding from a vessel in the polycystic kidney can become an issue, and patient can need to be seen urgently in the emergency room. And then, of course, pain can be due to tumor, and tumor does occur in polycystic kidneys. And therefore, if pain is a chronic ongoing issue, there needs to be a very careful assessment for kidney tumor. The chronic pain, often, as I said, it's the enlarged cystic kidneys. They cause stretching on the capsule or traction on the pedicle, which is the middle of the kidney, and of course the enlarged liver. So the KDIGO, which is a professional organization of nephrologists and people that are interested in various kidney diseases, the polycystic kidney guidelines from this group recommend that all patients with polycystic kidney disease at some point in their life should have some form of cross-sectional imaging to look for how their liver looks, how their kidneys look. And while there's no set guidelines for how often this should be done, they should have at least one at one point in their lives, perhaps at diagnosis or a few years into diagnosis, some assessment of the organ volume, and especially if they have pain, to try and identify where the pain is coming from. On the other hand, this person here, you can see, is a young person of mine that has polycystic kidney disease. And in this situation, you can see more large, plumper kidneys. Again, this person is probably going to have some mass effect. They're going to have fullness of their flanks. They're going to have perhaps some flank discomfort, trouble perhaps tying their shoelaces. This person actually has no pain. This is why I use this to show you that often there's really no correlation between someone with perhaps debilitating pain and someone that has no pain at all but large kidneys. And so the point I want to make here is that cross-sectional imaging may be helpful, but often there is a discordance between the amount of pain from the organs and the findings on imaging. So the very classic paper was written by Ted Steinman and Dr. Bajwa, an anesthesiologist. Point I want to make from this paper published in the early 2000s that the pain patterns in patients with polycystic kidney disease is much the same. Or, you know, it's back pain that patients report in 62%, abdominal pain, leg pain, going down the leg, radicular pain. Headache is a very common symptom in terms of polycystic kidney disease patients, and some patients get chest pain. And again, this may be because the cysts are pushing up, the liver is pushing up. And back pain is quite frequent. It can be constant in about a third of people. It can be daily. You may suffer from back pain daily because you've got big, huge, weighty, heavy kidneys. You may get pain once a week from your back pain. So as a physician, and as a nephrologist, when I see a patient, we ask about where the pain is, where does it go to, what kind of pain it is, how severe the pain is. And we can learn about the characteristics of pain, which can help us to understand how to treat your condition. And again, the abdominal pain, about 13% of people have this constantly, all of the time, 13% daily, once a week, about 9%. So these are very common symptoms. And so pain in the abdomen could be from the kidneys, it could be from the liver, it could be from something else, it could be from something completely not related. So some of the work in the last 10 years comes from some of the larger studies that were done. For example, the NIH Hall study described some aspects of pain and found that it was an early symptom. It inversely correlated with kidney function. So as kidney function went down, pain tended to be more often, more severe, and there, especially though in people with kidney function less than 45 or stage 3 kidney disease, impacting on quality of life. In the tolvaptan study, this was an industry-sponsored study. They did collect, however, in over 1,800 people, the adverse events, and were able to do some analysis after the clinical trial of the drug was done to look at significant pain-related adverse events. And I'm going to show you some of that data. And in that large study that was done, about half of the people had a history of kidney pain. The Reprise, which was another study that expanded the experience of tolvaptan, again, industry sponsored, there seemed to be in more advanced disease in this cohort, that with more advanced polycystic kidney disease, less kidney and back pain events. And then there's some very significant data from Korea that I usually discuss, showing patients with polycystic liver disease and people with very large livers. And in addition, they may also have very large kidneys. The two organ sets together tend to be additive, and the risk of pain symptoms was 5-fold increased when people had a very large liver. So it's very important to have a look at the liver, especially if you're having right-sided pain or abdominal fullness or feeling full quickly into a meal, because this may be due to symptomatic polycystic liver disease. And this is not that common, so I don't want to scare people that are listening to my talk, because people get alarmed when I give this talk, when they see people with large livers. Not everybody has that. In fact, most people do not have a very enlarged liver. It's just that some people do, and about 16% of patients with PKD tend to have symptomatic liver disease. And so those patients do need to come to specialized centers that can handle surgical approaches to alleviate the size of the liver and its compressive symptoms. And again, there was another study from Japan looking at cross-sectional descriptions of pain. So there's been quite a bit done, and others are studying this and funded to study this. So again, what could be causing the pain? Well, infection. So occasionally patients may feel unwell, have urinary symptoms. And the problem with PKD is that the lower urine infection, perhaps cystitis or bladder infections presenting with burning or stinging, passing urine, discomfort over the bladder, this infection can ascend quickly. The bacteria go up the urinary tract, and one can get infection in the kidney known as pyelonephritis, which can be a severe infection and can even lead to bloodstream spread of this infection, and needs to be treated and evaluated promptly. But this can be painful. And the problem with this is that sometimes the cyst can become infected in the kidney on that side. And that is another medical emergency. And those patients really need to be assessed quickly. Imaging needs to be done. And ideally, it should be contrast enhanced imaging to see if there's an infected cyst, because sometimes these need drainage. Again, when patients develop severe acute pain, this could be due to hemorrhage in a cyst, and often that can be in either kidney or liver. And then if some cysts are expanding over time, patients can report mass effect, and that can be kind of a fullness symptom, pressing on the surrounding kidney tissue or the surrounding muscles of the back. And then you can get acute expansion of cysts, for example, a cyst bursting. This can cause acute pain and can be quite moderate to severe for some people. They may need to lie on the couch, take a few days off work, take a lot of fluids, get fluids in the emergency room, and may need moderate pain and pain medicine or even IV pain medicine. And again, the renal capsule is the saran wrap of the outside of the kidney. And of course, when you have polycystic kidney disease, this is under a constant tension. So if there's shifting of cysts, which there always is, this can distend the capsule. And what's important about the capsule, it's the capsule of the kidney has a lot of pain fibers in there. So it's sensing this pain. And so this may give a deep type of pain sensation to the individual affected. Then we see people with kidney stones. So you can have kidney stones in both or one side. These can be either uric acid or oxalate stones, and these occur in about 20% of people. And you may be lucky that you don't have passage of a stone, but sometimes you can have passage of a stone, and that's called ureteric colic, colicky pain. So it's a waxing and waning pain that lasts minutes or so, about 20 minutes, and then it builds up, it crescendos, and then it decrescendos, it wanes off as the muscle of the ureter is trying to expulse the stone if the stone is about to pass. Now, most people can have stones and they may not pass or obstruct, but if they do, then you get this renal colic or ureteric colic, and it can even cause obstruction. And then we see patients because of hernias that are commoner in people with polycystic kidney disease. One can get complications from a hernia, for example, incarceration, which means twisting of perhaps bowel into the hernia. The commonest hernias we would see in people with polycystic kidney disease would be umbilical hernias, so in your belly button, near the belly button, para-umbilical hernias, abdominal rectus abdominal wall hernias are quite common, and then inguinal hernias in the groin. So they can have passage of bowel into the hernia or the outpouching of the wall of the hernia, and this can lead to torsion of the contents and a surgical emergency. So polycystic kidney disease is one of the most important non-urologic conditions to cause kidney pain, and in the past, we've written a descriptive article about what should be done, looking at a flow chart for how it can be handled. Of course, simple pain, rests, staying off work, getting hydrated, staying hydrated, and sometimes a heating pad was sitting in the whirlpool. One of the patients I'm going to show you today, she bought a memory foam mattress. Other patients tell us they like to sleep in an easy lazy boy chair. They don't like to sleep in a bed if they have a lot of chronic pain. If you have the acute pain, you may need to take some time off work, use these physical measures, and then simple pain medicines like Tylenol, occasionally a day or two of non-steroidals, alleviate. While it's not recommended to take them long-term, if you're having acute pain, they may take the edge off the pain for you. Another pain medicine that's safe in patients with kidney disease is tramadol. That medicine, known as Ultram, is well tolerated in most people, and it's responsive for moderate pain. Clonidine is a blood pressure medicine, traditionally considered a blood pressure medicine, but it's an alpha blocker medicine, so it has effects on the alpha side of the sympathetic nervous system and can block pain centrally. And then some patients, unfortunately, do need to take some low-dose opioid medicines like oxycodone, hydrocodone, hydromorphone. And these, we would really recommend just to use these sparingly in episodes of acute pain. And we try to avoid individuals being on these medicines long-term, since they have some physical and psychological dependence associated with them, can affect alertness, and tolerance builds up to the pain medicines. So the body gets used to the pain medicines and they become no longer effective. So we try to avoid individuals being on these medicines. And one of the things we hear a lot from patients that come to see us is that, oftentimes in smaller hospitals or clinics, perhaps pain clinics, when they don't know of other options for management of pain, patients may be prescribed these medicines and without other options being offered. Other options that are offered are there's quite a number. A TENS unit, electrical stimulation for back issues associated with large kidneys. Acupuncture may be helpful. Very rarely can we use a spinal cord stimulator, which would deliver a neuromodulation, or we can use a spinal opioid infusion. That's very rare that we've ever done that, but it is an option. But more and more, we're using surgical approaches to decompress cysts that clearly associate with symptoms. I'm going to show you some examples from liver and kidney and some examples of denervation approaches that we use. And not on that slide is that now we have an approved medical therapy in the form of tolvaptan that clearly modulates pain. So my first case here is a 33-year-old woman with polycystic kidney disease who presented to the emergency room with a 2-day history of flank pain on her left side. And when she presented there, she was found to be in acute kidney failure. So her creatinine had gone up, perhaps her urine outputs were low. A few years ago, she had had a similar event when she bled into a cyst. And so on this visit, it was decided she needed to be hospitalized, given some IV fluids and antibiotics. And when she came to see me, her pain had improved since the emergency room physician visit. However, she was continuing to have pain at night, and she's a mother with young children and working, and this is very inconvenient for her. And so you see here on the CT scan of her abdomen, this is a cross-sectional coronal CT. You can see the spine, the liver, the kidneys, and you can see in the upper pole of this left kidney here, which shows a bunch of cysts growing out of the kidney like grapes, and this one too, that this kidney is considerably much more distorted and correlates with her left-sided kidney pain. And what's going on here, as we try to visualize it here in this imaging, again, I have much more dense files to look at when I see the scan, is that this individual, this lady's having a hemorrhage into a cyst here, causing her pain and pushing on everything. And so this lady was overweight. She was resuscitated in the emergency room with fluids and given antibiotics for fear that she had infection, because often when you have a cyst hemorrhage, you can have fever as part of the inflammatory response. And she was able to continue, and then she was taking some pain meds at night to relieve this pain, but she came seeking other options. And so for this lady, we told her to lose some weight, get her on the proper diet for polycystic kidney disease patients with renal insufficiency. And we put her on tolvaptan. She was a candidate for tolvaptan therapy, and that's where she went. So this is a case of a cyst hemorrhage, an acute cyst hemorrhage, acute pain. First case. So now here's another case. Again, this can be associated with fever. This is a patient of mine that you can see with a very large liver with cysts in it, and you can see a kidney here on this part of the scan, and you can see here a round, very large cyst in the liver, and you can see there's a rim around it like an orange. And what this is an infected liver cyst. So this person may have abdominal pain, central abdominal pain. They may have fever. They may look unwell. They may develop acute kidney failure in the setting of an infection. And there are some criteria for diagnosis of the liver cyst. For example, the imaging criteria, as shown with this example, with the enhancement of the contrast around the cyst, the large cyst, the tenderness on examination associated with this finding on imaging, elevated inflammatory markers. And in this case here, this person really needs to have this cyst aspirated so as we can identify the bacteria in the cyst, culture the fluid, identify the correct antibiotics to be on, and perhaps treat this person for several weeks. And if the cyst infection comes back, they need to be retreated again or perhaps put on long-term antibiotics. And this I'm showing you to you because it's an important complication of polycystic liver disease and is frequently missed, and patients frequently keep coming back to their doctors trying to figure out what's wrong. And in fact, there's a deep-seated infected cyst in a liver and kidney. This is an example from the literature that I produced here for this slide, showing again a cyst infection in a polycystic kidney, and picked up with debris in the cyst on ultrasound, density on the CT scan, some enhancement around the edge. and heterogeneity or various kind of densities on the pixelation on the scan. And again, in this case, it's important to be quickly evaluated, and in a specialty center like ours, we would attempt to drain this cyst because this person could quickly decompensate, the bacteria could spread to the blood, and it's important to remove the bacteria and pus from the cyst if there's an infected cyst in the kidney. Now, we recently published this little review article about an approach to abdominal pain in polycystic kidney disease in nephrology, dialysis, and transplantation, the European Journal, showing kind of a workflow for what we would do. The person comes in with acute abdominal pain, perhaps they have fever or not. We look at the vital signs, whether they decide quickly whether they need to be hospitalized. And often in our center, and we would encourage in other centers, that the patient have their physician, your doctor, work with the emergency room physician, especially if you've had this happen to you several times, that you've been to the emergency room with acute pain. And so the nephrologist, me as a nephrologist, I can help the emergency room physician to figure out where the pain is coming from, the loin, the hypochondrium, what part of the abdomen, what are the markers of kidney function, make sure a urine culture is done, get the patient on some fluids, get the patient to the hospital if they need to be admitted, and get the right kind of imaging. And this is a question the PKD Foundation asked me, that patients contact them all the time asking what kind of scan. Well, it's difficult to say in most cases because everybody has different kidney function. But in a situation where we have a potential cyst infection, which is life-threatening, sometimes we do need that contrast, that iodine with a CT scan. And of course, a CT scan is going to be done in a place that has a good CT machine, but if you don't have that available to you in your hospital, it may be an ultrasound. But really, we like some kind of cross-sectional imaging, and a good quality CT scan, ideally with contrast, helps pick things out that might otherwise be missed if contrast was not given. So the causes can be not related to the cystic disease at all, or it can be stone, passage of a stone, a gallstone disease. It could be an acute hemorrhage. This can be visualized, especially when contrast is given. And one can decide that based on the Hounsfield units or density seen. Cyst infection can be readily identified. Sometimes it can be missed. And then sometimes we have to rely on other more sophisticated forms of imaging, such as PET scan, which is particularly helpful in liver cyst infection, abdominal MRI, if the hospital or center has that type of scan, that's very high level, high resolution. And in more infrequently, we do rely on a nuclear scan that labels the white blood cells that can pick up a focus of infection and can help us identify occult infection as a cause of pain. The treatment involves pain management, hydration, and there's a drug called tranexamic acid. I will show you some cases where that can be used. And of course, antibiotic therapy, and I mentioned drainage from the cyst. So this is an example of somebody with a kidney stone here. This is a CT, a stone CT that we do at our center. And you can see the Hounsfield units, which is the density is compared to the density of the bones in the spine. And then we can tell the kidney stone in the cyst, in the cystic kidney, how dense it is. And we can then tell what kind of stone it is. Is it uric acid? Is it calcium oxalate? Or is something else? And so stones, I mentioned, are an important cause of acute pain. They can also cause flank pain chronically. They can lead to blood in the urine, obstruction, infection, and sometimes need surgical procedures. And I'll warn you, for those of you that have had these procedures, sometimes the treatment may be worse than the disease because patients come back complaining about the discomfort of the stent, the painful lithotripsy or stone blasting procedure that they had, the painful surgical procedures to retrieve the stone. And so in this case, actually, the management here, what was done for this person was actually to put the person on allopurinol and put them on citrate because they had low urinary citrate, and they also had a uric acid stone here. And this stone actually dissolved with medical therapy and didn't need a surgical intervention. Case 2, a 44-year-old man came with abdominal pain. A few days before, he had had gastritis and harsh episodes of vomiting because the abdominal pain subsided. But when he came to the emergency room, he was having some pain and some tenderness in his left lower quadrant or left lower corner of his abdomen. And this pain was getting worse and he felt nauseated and sweating. So he went to the emergency room and his kidney function was normal. And the CT scan again was done to assess the situation. And they felt that there was a colitis or an inflammation of his descending colon. And he was given some antibiotics, put on clear fluids and sent home. But then the pain came back on Christmas Eve, of course, most inconvenient. Pain recurred, and he was now hospitalized for 6 days. And again, with inflammation, his descending colon. Now, I point out here that patients with polycystic kidney disease can get colitis, they can get diverticulitis. But actually, this is what's going on. This person, again, you can see has polycystic kidneys, very large cysts here in the right kidney that are bursting out. And you can see preserved kidney here. And then you can see here this heterogeneous appearance to this cyst down here. And you can see that there's some dense material, and this is actually a bleed into a cyst. Okay, so this is the initial CT scan, but then this is the scan 6 days later. So what you see here is that this bleed into this cyst is now extended, and it's outside around towards the spreading out on the cap around within the capsule of the kidney, which you can see here. And then there's the extension of the bleed here along the retroperitoneum or back of the abdomen, and it's pushing on his muscles, and he's having pain in his lower abdomen and his low back with this. So this is potentially life-threatening. He's having a big bleed into a cyst hemorrhage, and a retroperitoneal extension of that bleed. And so these patients have to be hospitalized. Sometimes we have to do an angiogram and to try and stop the bleeding, or we can give therapies. So this is another image of the same patient. You can see that the clot is now much larger. This is, you can see now the contrast CT. You can see that the kidneys are lighting up with the contrast. You can see the extent of his polycystic disease, and you can see we're getting a good handle on this large bleeding cyst here, and now that has developed into a hematoma.
Bree, you have about 15 minutes left. Thanks.
Very good. So the treatments can be tranexamic acid when there's bleeding like this. He was taking a headache medicine, Excedrin, which contains aspirin, so this was stopped, resting him, and sometimes we embolize. And so it eventually regressed, as showing here. So we monitor him. And in patients that are unstable, we'll do an embolization. We'll block off the blood flow to this bleeding cyst. And that's done by interventional radiology, and it's an emergency procedure. So those are the references for those treatments. I mentioned tolvaptan as a treatment option that modulates pain. You've probably seen these data, but there was a difference in pain, less pain in the tolvaptan treated arm of the Tempo 3/4. So tolvaptan is a treatment option for many people with PKD. So next slide. Again, this is just the tolvaptan data, and that trial is over and tolvaptan is approved, so your nephrologist can get you on the treatment. But there is a forthcoming lixivaptan trial, and we did a single patient trial of lixivaptan in a young lady with the chronic disabling pain, and she tolerated this treatment as opposed to tolvaptan, which led to liver abnormalities. And so the Palladio are planning a large study to examine lixivaptan and other tolvaptan-like medication in a global trial to study this in more detail, and we'll look at pain. So this is an important summary slide, just showing you the treatment options that can be done for different causes of pain, from going in with a needle and aspirating a cyst, which we don't do very often, but sometimes we do as a diagnostic test. More often what we do is a cyst aspiration, and we put foam into the cyst to treat it, and that can be both liver or kidney. Sometimes we go in with keyhole surgery and take out a bunch of cysts. This is a day procedure, the sclerotherapy that's done in the radiology department. This is an overnight hospitalization. And the procedure we do a lot now is foam sclerotherapy. I'll show you some cases. You can do bigger surgeries, of course. We'll talk about nephrectomy. Nerve blocks are often done. They can be done as a temporary procedure or a more long-lasting one. Liver surgery, ablation of the blood flow to the liver or to the renal artery, to part of the liver to reduce the size, can be done, and is done in some countries more so than here in the US. And then liver transplant for people with very severe polycystic liver disease. Now this person here, case 3, has huge polycystic kidneys. You can see here, engulfing their whole abdomen. very mild liver disease, little cysts in there, and there's a cross section of the cysts, and you can see that many of them have fluid levels in them from the bleeding, thick proteinaceous material. This person we know had kidney pain because he's a case we had, so we know he was having pain with these from intermittent bleeding cysts, and he was on blood thinner or warfarin, which didn't help, and then he bled into a cyst, as can be seen down here and on this. So this person has highly symptomatic polycystic livers, polycystic kidneys that are huge. So this person, what we offered him in the end, as his kidney failure advanced, after he'd been on tolvaptan for several years, he was offered bilateral nephrectomy at the same time as a kidney transplant. And this is the procedure that's done at our hospital, where we can take out the polycystic kidneys, both of them, one or both of them at the same time, and implant the new kidney transplant in the lower quadrant. And so this is a big surgery. It is safe and feasible at the time of the living donor kidney transplant. More blood transfusions needed, and the patient may need to be observed in our ICU overnight. Other options are doing nephrectomies after the kidney transplant, which is mostly what we do, but we're doing more bilateral nephrectomies and simultaneous preemptive kidney transplant in our center nowadays. So I'll go on now to a fourth case, bilateral chronic flank pain. This man is a patient of mine, chronic stage 3 kidney failure. He eventually went on tolvaptan for bilateral flank pain from these polycystic kidneys. And then eventually he really was very uncomfortable, and he wanted something more definitive done for particularly the left kidney. So what we did was a denervation procedure, which we can do up through the groin, through the blood vessels. So we've done a number of these now, and he got relief from that. And this is an approach that's used in other centers. For example, the DPAC, the European group, are denervating in some patients with polycystic kidney, the nerves going into the kidney. And so this is called renal denervation. And they have a kind of a process for that, doing temporary nerve blocks first to see if that works. Whereas we have moved largely to denervation as our primary treatment option for patients with chronic pain, where we don't see, where we can drain cysts, or they're not ready to have a nephrectomy yet. And this is safe. We do it, it's an overnight hospital stay. And so these are the results of their study in the Netherlands, showing that this was safe and feasible. And again, they offer this to patients with other kidney diseases in addition to polycystic kidney disease, and they found the pain was improved with this procedure. They did well, it was safe. Now, many patients, as I said, are only offered opioid therapies, but I want to point out, it's an important message of this meeting with patients today listening to me, is that really there's no sufficient evidence to say that long-term opioid pain medicines improve chronic pain at all. And we try to get some other options for our patients at our center. And so I'm going to move on now to the liver, because the liver is an important source of pain, and often both kidney, being kidney volume here and liver volume shown here, as both organs enlarge, the pressure-related symptoms causing the pain get more constant and more severe. So the huge kidney compared with the normal kidney, and the huge liver. And sometimes this needs removal of some of the liver in a subset of patients. This person here has severe liver disease, as this woman does here. Often it's a disease more of women, but we do have men that get it. And again, this person has an abdominal hernia. You can see the symptoms of polycystic liver disease, again, are overlapping with the kidneys, loss of appetite, shortness of breath, pain in their flanks, back pain, abdominal fullness. And some of patients are needing daily pain meds. And so there are a number of interventions. One medical intervention, which is an off-label use. We have done trials with somatostatin analogs, and they're very effective, but proton pump inhibitors and H2 antagonists can help with potentially some of the secretory mechanisms. And then there are surgical approaches. And so this is a person, these are 3 people here that were in our clinical trials with octreotide. And on the top of these pictures here, you can see the organ volume of the livers. And you can see there's a substantial reduction in organ volume in some individuals with very symptomatic liver disease. And this is a very viable treatment option for those patients. Although it is expensive, we are able to get it as an off-label use or through the patient assistance programs of the company that makes that drug. And patients can get it once a month as an injection, and it slows down the liver enlargement. So just to point out this paper 3 years ago, that biliary disease can occur. So people with polycystic kidney disease can also get gallstones. So if you get pain in your right side, you should be checked out because you have a twofold higher risk of getting gallstones. This is from a chart review in Oxford in the UK showing that there's commonly gallstone problem. From chart data. And so the people that have large cysts that can be drained, we've done sclerotherapy with and injected alcohol into the cyst to clean out the cells inside of the cysts that drain, then make the fluid that fills up again. If you don't put something in the cyst, these cysts tend to come back right away immediately. So we hear that a lot, that patients go to a center and they take the fluid out, but they don't put back anything in the cyst. So we show here the spidergram how quality of life improved after alcohol sclerotherapy, and it's very effective. But now we've moved on to a treatment called foam, and this is a patient of mine. We did liver and kidney cysts. We took out this liver cyst here, and then a couple of kidney cysts at the foam procedure, a day procedure. Then this cyst did come back because it's very large, and she had a laparoscopic or keyhole surgery to remove that, and you see a very nice result. And then eventually, though, she went with advancing kidney failure, had both kidneys taken out, and a simultaneous living unrelated kidney transplant last year. And so she's very happy with that result. This is another person who had foam sclerotherapy of a couple of cysts, one of my patients here. So we targeted these two cysts here, pressing on her stomach, which is this ball, this round thing here. And so this is just last week when she came back to see me. You can see she's had a very effective result from foam sclerotherapy, and she's thinking about doing a few more cysts in the next year or so to help her symptoms. I don't have time, Nicole, to go back to this, but I just wanted to move on in this talk now just to show we take out a couple of sectors of liver. This is a bigger surgical approach for liver disease, hepatectomy. And I had an image of a right side liver sectorectomy removal from case 7 and case 8, a 41-year-old woman where we did a left. So we take out the left side of the liver to create space. And this is the before and this is the after for this lady who's done well. And so in general, we take out about 60% of the liver with these procedures. This needs to be done at a very specialized center. A few places around the country are regularly doing this. It has a mortality associated with surgery, but our results are generally very good and patients are very satisfied. But you must have 2 segments of liver that are relatively free for cystic disease in order to be able to do this type of surgery. But it is very effective, as shown here. We have a 60% reduction in liver volume, and I can answer more questions about that at the end. The Toronto group at University of Toronto have been doing the foam sclerotherapy and published their kidney cyst cases and had a very nice result with reduction in organ volume. We're also doing liver cases routinely. And then I'll show you an example, but these are their cases. You can see their pain improves with the foam sclerotherapy, which sticks and glues down the cysts so they don't come back. And we just submitted this abstract to the ASN showing a case 10 here, where we have somebody with very big, large polycystic kidneys, and they kept coming back wanting more sclerotherapy sessions. So we did 5 here, the first one, the second one, the third one, the fourth one. You can see their total organ volume has gone down substantially, 800 cc's with a couple of cysts drained each time over sequential visits for outpatient sclerotherapy. So some patients are wanting that. They're very happy with the result. This is somebody that has severe polycystic liver disease. She asked me to show you her image today. She's 50. She's waiting for a liver transplant because she has very severe disease. And as you can see here in her abdomen, she has fluid in her belly, multiple cysts in her liver. And she cannot sleep because of the pain. She's using Tylenol. She lies on her back. She's the lady that's bought the memory foam. She has early satiety, feeling full quickly because of this mass in her abdomen, weight loss, 10 pounds, chronic heartburn because the liver is pushing up. And so this is her scan I want to show you from 10 years ago. So she came to us last year, and you can see at this stage, she would have actually been a candidate for a liver resection surgery. We could have taken half of her liver away. Now she regrets not having been referred earlier to our center because she missed that. She wanted you to know that she missed the window for liver resection surgery, and she feels this could have delayed her kidney failure progression if it was done back in 2016, a couple of years before. And then that resection might have slowed her liver progression and hence her time to liver and kidney transplant. And now she's waiting for a liver and kidney transplant. There are important developments with liver transplant in polycystic liver disease recently by UNOS, who have relaxed the criteria to push patients like this lady up. And so she's going to get a liver transplant in the next month with the changes in the MELD criteria. So the foundation just asked me to discuss with you that they receive a lot of comments from patients about how to approach this problem with your care providers, how to talk about the risks and the benefits of these procedures, and when to go elsewhere for treatment. Well, take home points, you can't just go anywhere. Not every hospital, not every clinic is set up for this. You need places where there are interventional radiologists familiar with this disease, where there are pain specialists, liver surgeons, kidney transplant surgeons, interventional radiologists that have expertise, and to look for specialty centers. Find a supportive medical doctor to support you with a good practice nurse that can help you. Avoid the emergency room, avoid opiates. And if you have to go to the emergency room, get your medical doctor or your nephrologist to talk to them there while you're there, and seek specialty care. In summary, there are many different causes of pain. The studies are there to describe these causes of pain. Now, the imaging is very important, what you need to know, what to look for, and there's increasing interest in this area, improving care. There are effective medical and surgical therapies for you, and there are alternatives to opioid therapies, but multidisciplinary medical teams are needed for this. Thank you for your attention.
Dr. Hogan, thank you so much for this presentation. A lot of very helpful information, and I know that I speak for everyone when I say how much we appreciate it. You really answered and touched on all the questions that I was able to pull out of the chat. So maybe a final comment to leave us with, what are maybe symptoms associated with pain that would lead you to some type of intervention? Because we did have some questions about nerve block, cyst decortication, or deroofing surgery. So are there clinical reasons that you would move towards a procedure?
I think if it's really impacting on your quality of life, you should look for options and not just suffer on. I think if it's really bothering you, or if you're requiring a lot of medicine, or you're missing quality time with your family or friends because you have to lay home on the couch, or you're missing a lot of time off work, you should seek out a specialty center and get looked at. And you can bring your scans with you. We don't necessarily always need new scans. You can get your scans now uploaded digitally. We can look at them, and we are doing virtual consults. We can do virtual consults with people from around the country and look at their scans and discuss what's going on, so you don't have to spend all that money traveling to a specialty center. With telemedicine now, we can do a lot as well. So I think, quite moderate pain, chronic pain, and then if you're having a lot of acute pain episodes, if you're passing stones, and those kind of things need to be checked out.
Thank you. Thank you very much. So I want to take this opportunity to thank you, Dr. Hogan, for being with us today and sharing this information.